May 13th. I think Mr. Cheatham may be walking in as we speak, but we'll go ahead and get started and kind of go through some, what we're going to be speaking about. The only item on the agenda is discussion and possible action results of the RFP for administrative service for self-insured health and dental plans. And I just want to clear up a couple of things. There's been some emails going around and phone calls going around and text messages going around and all kinds of things like that. One, that this is a process that started 8 months ago when we went through the budget, looking for everything we could do to help with employee pay raises. So we decided to look at every facet of our system. We also looked at Medicare Advantage during that time, which did save us some money, but it was to the detriment of our retirees and our employees, so we surely voted against that measure. It's not a secret meeting trying to push through an agenda item in the middle of the night on switching insurance companies. Because, by the way, just to make everybody understand this, we are self-insured, which means we are the insurance company. We pay all the bills. It comes out of our budget. We don't have to rely on any company to pay our bills for us because it's a self-insured insurance plan where we are the payer for all the claims. What else here? Alright, so tonight what we're going to be doing is we're going to hear from, we had two companies with the RFP, and the RFP was sent out 8 months ago basically saying it hasn't been done in 9 years, almost a decade, and we thought it was time to at least put a little competition in the market to try to save some valuable dollars that we can maybe reallocate to different parts of our budget. And so we started that process about 8 months ago. We are just now getting some of the responses back. And so all we're doing tonight is going through some of the responses and some of the bottom line numbers that go along with that. And that's going to be shared with, we've got some emails on it, so we were privy to the information, but we'll be sharing that publicly tonight with all the people that are concerned about it. The way that'll look tonight is we'll have a 10-minute presentation by representatives from Aetna are here, so thank y'all for coming in for this. And that'll be followed by a 10-minute presentation by Blue Cross Blue Shield. Thank you guys for coming in. Brad, did you fly in or did you drive in?
Yeah, helicopter from
helicopter. And then after the two companies visit with us, then we are going to have Jason Allman take over the presentation from there and give us some information that he's compiled for us. So just to let the representatives from Aetna and Blue Cross, I'm going to have a ticker up here so we can stay on time. And so it'll be 10 minutes, kind of pretty quick, and then I'll give you a little heads up, and we've got about a minute left in your presentation so you can start wrapping things up.
And I would respectfully ask, we have an individual stuck in traffic. Would it be very possible to split the order?
Oh, I don't know that would matter. So, y'all know airline route traffic was bad? Yeah, there's no opposition to that. I mean, I don't think they flipped a coin to determine the order of speaking, but Brad, y'all are ready?
Yeah, we're ready. Yes, sir.
Okay. You have 1 minute.
1 minute.
Thank you. Hey, good evening, everybody. Thank you for having me. It's a great opportunity to be able to come and speak to you all. I want to first start off with, we have some folks here that work in the Shreveport office. I'm going to introduce them and then get into the presentation and go from there. So I have Mara Alexander, who is your account manager located in Shreveport. And then I have account executive Jonathan Dore. He's located here in Shreveport as well. So I wanted to bring them out and introduce them and, show them, I guess, how the real committees run, so to speak, in Mosher Parish. So they had to cross the river and come over, but they're glad to be here. So I'm going to go through the presentation. You'll have the numbers. I'm going to hit some highlights, and what I'm going to do is kind of tell you some things about Blue Cross that you may not know about. You may know, you may not. there's many facets to a self-funded program. I kind of want to hit some highlights there. But what my presentation theme for this evening is local partnership and facts. Okay? Let's keep those two things in mind. So to begin with is, a self-funded program is composed of many different parts. To start off with, it's composed of the admin fee. Admin fee. We've presented an admin fee in the RFP, and our admin fee is very competitive. It's going to save you money over what you're currently paying, and it's a 3-year agreement. What's included in that admin fee is claims administration, network access fees, CO coordination of benefits, annual ID card mailings. We got preparation of the plan document is included. RX savings solutions also included, and we also have case management. So we have disease management, case management. You'll have these proposals, I believe, in your file, but I'm just hitting some of the highlights on that. And so that's what's included in our admin fee. We also have some care management program. It's called the AIM program. It's a high-tech program that's included in your admin fee. And so, as you can see, it's a comprehensive proposal, which includes many facets to the admin fee. Another thing that what's included in your on being self-funded is stop loss. That's something Jason will hit on. Jason also hit on the numbers. I'm gonna let him handle the numbers in detail, but I just want to kind of go through some things with what Blue Cross offers and the partnership we have with the Bossier Parish School Board. Medical claims. We've proven that we're able to save Bossier Parish School Board a substantial amount of bill claims. I've got a paper in front of me here that I just ran. It's actually through the month of April 2021. It's a 68% discount of bill claims. And that includes coordination of benefits. But bill claims, we're substantially lower than what you would bill. And so that entails that it saves the board money. It saves the employees money and the members as well. Another facet that's included is the RX claims. Bossier's unique with Blue Cross. You have what they call a full pass-through. You get the manufactured administrative fee back. Everything rebates. The dollars that you get back monthly, $450,000 on average on drug rebates you get through us. We don't keep any of that. We don't keep a percentage. We pass it all through back to Blue Cross. To the Bossier School Board. Y'all did implement a few things. In 1-1, a closed formulary to all active employees. You introduced a Part D with programs for retirees. New changes. Those are new things to the members, and we've been very supportive in trying to help guide members into that. We have a team down in Baton Rouge of about 11 pharmacies that do nothing but analyze new prescription drugs that come through to make sure that nothing falls through the cracks of being compound medication. Those astronomical compound medications that may come through that may be that somebody may get a prescription on. They cost the board significant money. Disease management, that's another facet of the self-funded plan. We have 2 local nurses in Shreveport. They go and help members at the pharmacy, at the doctor's office, at the hospital, in person. They'll go visit those members in person. We have a senior medical director located here in Shreveport. She looks at appeals every day to see what's going on. So she reports directly to our CEO. Then we have several nurses that handle nothing but case management. Also, we have coordination benefits, which I hit on in our admin fee. We charge nothing, but that's included in our admin fee. That helps with coordination with, you do recover retirees, so Medicare, coordination with Medicare, and then other coverage. Drug subsidy, that's kind of last year you were able to recoup about $900,000 because we were able to supply some information to the administration to be able to help you get $900,000 back from CMS, and that's money in your pocket. That's real money. That'll go away as you put in a Part D program. Partnerships with our providers. Nothing like trying to find a doctor or refer to a doctor that maybe not in network or whatever the case may be. We have 99% of our doctors in the network in all the facilities in the area. So there hadn't been any disruption. There should be disruption in care when you refer to a doctor. That includes its anesthesiologists, radiologists, pathologists, and ER docs. We have a group reporting tool that helps staff be able to look at how claims are running. That's at their fingertips. Quality Blue. This is a pretty neat program. It's kind of a concept. If you go see a Quality Blue provider, a doctor, a primary care doctor, they actually are not trying to run in as many patients as possible. They're paid by Blue Cross based on their patient outcome. So if they have healthy patients, they get paid a little more. If they don't have healthy patients, they don't get paid as much. So they're basically paid on quality of care. And that's the only way you're going to be able to reduce this insurance, be able to reduce claims. Benefit Insights. We had a meeting a couple months ago. Dr. Whittington, who's a MD down in Baton Rouge. Kenny LaCoste is a pharmacist down in Baton Rouge. Amy Yoshi, she's an RN. And then we had Michelle Graham come up and give a detailed synopsis of how Bossier's running on claims. Gave some examples. Gave some input on what they could do or what Bossier could do to try to help reduce claims. Also, before I get into the most important part of it, we honored the privilege to be able to issue an RFP. We treated this as an agreement. We went through the whole process. We answered every question. We submitted a bid, a very competitive bid, on time. And it was able to be able to do that. We repriced claims. We furnished a claims report to others, and we repriced it just like a new group would, and we treated it that way. So we did all that. We went through the process and was able to get that to Jason, your consultant, Mr. Alderman, in a timely fashion. Now, something that really stands apart from others. Local service. I just introduced. I used to sit where you were at. I was here. I live in this. I live in Bossier Parish. Whole family lives in Bossier Parish. Yes, sir. 1 minute. Okay, y'all better listen past that. So we're a Louisiana-based company. We've been here for 85 years. We only write companies in Louisiana. Nothing outside. It's in our name, Blue Cross Louisiana. We have 8 district offices. Do it from Freeport all the way to Houma, Louisiana. We're dedicated to Louisianans and help make sure that they have the right coverage in place. Our slogan is we want to improve the lives and health of Louisianians. And so we're in the individual market, we're in the small group market, fully insured, and so forth. So if a person needs to come over and see us in person, they can come over and drive to Ashley Ridge, sit down with one of us, and not be able to have to call an 800 number. Okay? One thing we've created was a Blue Cross Foundation. We give back monies to the community. That's part of our give back to the community process. American Cancer Society. Last year, we did an Operation Warm for Bossier Elementary. We gave 300 codes to people at Bossier Elementary that may have not been able to get a code. We give grants when they're offered. So some of the things that we do, local clients that we have Bossier Parish Police Jury, Citizens National Bank, McElroy Metal, City of Bossier, and so forth. And I just want to say, I know time's up. I see Mr. Van Perkins is here. I used to sit in this seat for 11 years. Okay, y'all have to make some tough decisions. We've created a partnership over many years with the Bossier Parish School. Let's continue that partnership and vote to renew Blue Cross, and we can continue to have that relationship. Thank you.
Thank you, Brad. 11 years.
Thank you, Ms. Bernberg.
I now our Aetna would like to come up with their team.
Thank you. And we have to split the four of us, so I'm going to have to talk fast. But we're so privileged to be here. My name is Cindy Fulmer, and I'm the president of Aetna for the Gulf States and for Georgia. And I had to come all the way from Atlanta, Georgia to try to find some gas. You all have gas here? It's a real privilege. Thank you so much for inviting us and giving us this wonderful opportunity to present what Aetna has to offer the school board. I just want to say a few words about Aetna, then I'm going to turn it over to my colleagues to talk about our proposal and what we're offering you. We are a Fortune 5 company, now that Aetna is part of the CVS family of companies. And we're very local. Most Americans live within 5 miles of a CVS. And so we have over 2,000 employees in Louisiana, when you count our Aetna and CVS employees. We have a little over 100,000 commercial members between our medical and dental products, 111,000 Medicaid members, because we have a contract with the state to manage the Medicaid program. We also have 20,000 Medicare Advantage members, 136 pharmacies, retail pharmacies, and 6 minute clinics throughout Louisiana. And no, while we don't have a monopoly in the state, while we don't have hundreds and hundreds and hundreds of clients across the state, I will tell you that an account of this size, the school board, you would be the most important customer in the state for us. And you would be getting all of Aetna's resources, attention, dedication, and full commitment. Because this would be a cachet account for us, and we would consider it an honor and a privilege to serve you. For over a decade, Americans have been demanding a new paradigm of healthcare. They want healthcare to be simpler, more affordable, and less fragmented. And Aetna and CVS coming together, we believe provides a solution that brings care closer to home, that makes care more affordable. Since we've integrated these two companies, we've been able to save people in our integrated medical and pharmacy programs $50 per member per month in additional savings. And these savings are continuing to build as these companies get closer and closer together. And again, being in your neighborhood, we can bring care much closer to home. So let's get right into the proposal and what we're offering the school board today. So I'll turn it over to you, Scott.
Thank you for flipping the time. That's much appreciated. Yes, sir. Good afternoon, everyone. My name is Scott Bolenbaugh. I'm the market head of sales for Aetna's Public and Labor team. Very proud to be here after the past year and 3 months. Very proud and privileged to be out in public again. So this is what we work for, and we welcome and so much appreciate the opportunity to be in front of you today. We also are very appreciative of having worked your proposal for the last, I think, going on 4 months, believing what we've put together is a wonderful, innovative solution for your group. And I want to speak to a few of those financial highlights that I think makes us unique. The first is, essentially under a self-insured plan, you have two components. You have a fixed cost component, which is your administrative cost for medical admin. And then you have the larger part of the dollar, which is the claims cost. And that's where the big spend is typically. So we feel like we've brought a solution that addresses both of those. First, on the medical fee administration, Aetna has proposed a 3-year contract, and we have waived all administrative medical fees associated with that first year of our relationship. And we believe that that's valued on current membership at around $920,000. So we would forego collecting medical admin fees for the first year of the contract. And then as we go into year 2 and year 3, we've included in our financial proposal a maximum 3% escalator on that medical administration fee. So again, it's not 1 year's free and then hit a high second or third year. That's not what we're proposing. We're actually capping up to a maximum of 3%. We also understand that change is challenging, change is difficult. You've had your current relationship for a very long time. To that end, we have offered a $30,000 implementation allowance It's often used for employee-retiree communication. It's used for open enrollment meetings to make sure that the plan is conveyed properly and accurately and where you want us to be to communicate the new plan. We also have included performance guarantees, operational performance guarantees that include things like claims payment accuracy, claims timeliness, average speed of answer when one of your team members calls into our customer service team. For those performance-related standards, we've put a total of 25% of our medical administrative fees at risk. And then also, wellness, improving the health of those we serve and helping those on their journey to healthy lifestyles. Aetna is proposing a $100,000 a year wellness allowance that we would look forward to collaborating with your team to work on the kinds of wellness initiatives that we think will resonate with your population and hopefully encourage everyone to get on a healthier path and a healthier journey. The last thing that I'll mention before turning it over to Thomas is the claims piece that I mentioned. We talked about the fixed cost. I want to just hit the claims piece, which is the bigger part of the dollar. We have guaranteed over a full final year with your current carrier, medical claims with Aetna in the new first year will not exceed a 1.6% increase, or what we call a claims target guarantee or a net effective trend. And for those of you who have been studying on our business, trend is many, many more times than that 1.6. We believe we can accomplish that with our collaborative provider partnerships we have in the local community, all the things that we do behind the scenes to assist and support the ones that we take care of as well. So those are a few aspects I wanted to touch on. I know we're running on time. Thomas, I'll turn it over to you. Thank you.
I'm going to go quick because I want to save time for Neil and our pharmacy side. My name is Thomas James. Thank you for your time today. Good afternoon. Vice President, and I am in charge of sales and account management for Aetna for the entire region. And I wanted to let you know that we saw your coverages that your consultant sent over to us, and yes, we quoted the medical pharmacy. We put a quote on the table for dental as well, pay flex for your COBRA administration, as well as stop loss for reinsurance. We understand that change is never easy, but it's inevitable sometimes. And we're putting this proposal together to let you know that we're here. The city said that we're going to focus on you. You're our only large client in the state, and we're going to put our money where our mouth is. If you look at your cost proposal and you compare it to the past, you'll see the dynamic change that Aetna has brought to the table and how we moved your pricing and how we're controlling your cost containment to improve. So if you look at the last 10 years of what you've been going through versus what we put to the table, we can always have a horse race to the bottom. There's always be $1 cheaper than the other guy. But what I want you to look at to see what the future could potentially hold for you is the accountability that we brought to the table to you today in your price, and compare it to what you've been doing last year and the year before. And look at our guarantees and our performances and what we put on the table. And just compare it to yesterday. We can always make promises for tomorrow, but let's look at today, what we're proposing today, please, versus what you've been going through, and let that be a litmus test for what the future may look like for you. Today, when we look at your paid claims, which is what's important today, over 97% of your paid claims, we would be able to match that. We fall within our network. 97% of how you're paying your claims, the providers they're going to, is a match for Aetna today. Over 97%. And that's without recruitment efforts. So obviously, if we take you on, we have recruitment efforts, we can increase that. So that's very important. Also, I want you to know that when you think about this team and you think about the accountability that we have for public sector, we have a dedicated team. Yes, sir. Okay. Okay. I want to get the other one up here. But we have a dedicated team that focuses on your business that's separate from our commercial business that knows your business very well, and we want you to know that as well. Thank you for your time.
I'll be very brief with the minute I have left. I will say, I guess getting started, pharmacy benefits an interesting deal. And I had an old PBM guy tell me at one time, it's not really what you save, it's what you spend. And in looking at the data, you're spending too much. And I think a lot of that comes from the fact that you've got a claims process that's processing claims very well. But we see a whole lot of claims that need to be looked at with more scrutiny. Claims that are limited distribution type claims that are being filled, claims that are what are called, lost my train of thought. But anyway, you've got a number of different claims that are out there that today that should not be filled. We looked at the claims from top to bottom, and we looked at about $200,000 worth of claims. That these claims are claims that really they're hyperinflation. They're drugs that have gone up significantly in the marketplace that we don't even cover anymore, but they went right through us with the current plan today. So again, it's not necessarily that, the fact of the matter is that, again, when it comes to PBM, it's hard to really apple to apple when you're comparing these different offerings. We try very hard. We've provided a very aggressive pharmacy bid, rebates, discounts, dispensing fees, and so forth. So we look very closely at product selection, utilization, patient safety, and cost. We're pharmacy benefit managers, but we're truly data managers. And in coordination with the CVS stores, we have significant advantage. I use medical pharmacy lab values. Example, Agnes goes into the pharmacy, she gets a prescription for a narcotic for pain that may be pre-certified, right? The pharmacist calls the doctor calls the pre-cert line, so forth, back and forth. A couple of days later, she gets her drug. However, I know, because I have medical data from CVS Health as well as for our medical teams, I find that Agnes has a diagnosis of cancer. So I can pre-certify online real time. So we actually look at data 360 through medical, pharmacy, as well as lab values, disease state information, and we can process and adjudicate that real time. So we're making sure that we are outreaching quicker, identifying faster, and enrolling members in programs.
Thank you. Thank you, representatives from Aetna, for your information, and I guess we will turn it over to Mr. Allman.
Good evening. I appreciate your time. It's been a number of months going through this question and RFPs. We sent it out initially in September and then withdrew it because of the timing and where we were. We sent it out again in February. We sent it out to Blue Cross, Cigna, Humana, United Healthcare, Maritime Health. And at the time, I was under the impression Maritime Health and Aetna worked simultaneously. It's a company owned by Aetna that processes claims on a TPA basis, third-party administration basis. They sent it back and they declined the bid. Then we've got notice of an ongoing situation with negotiations with them and Will Stein, and Will Stein won the bid. And so we afforded the time to get the quote out to Aetna to get their bid in. Since that time, we've been going through proposals, information, trying to validate everything and make sure that when we're looking at it through eyes of what is best and what it looks like. What I've done tonight is I've put together some information for y'all, and it compares the information both on an administrative fee, on PPO discounts, and the information that was provided, and on prescription drugs. On the prescription drug information that we're going to look at is actually repricing. 114,000 prescription drugs were sent out to different vendors to validate and put through. The hard thing is that the information presented included claims that were through the formulary before we moved to the closed formulary, so some of it kind of shifts, kind of makes it look like some things would be covered under the closed formulary that's not. So some of that information may be a little bit different in actual use today. The first thing I'm going to go through is the spreadsheet on admin. And then the spreadsheet on the information pertaining to the discounts and then on prescription drugs. If you look at the information that's in front of you, the first column is Blue Cross. And these are based on their admin fees that we'll go through inside of the overview that I've done for each one of the groups. And if anybody's got any questions, they can ask. But the admin fee, and this is all based on the same enrollment utilized for each person, and it may be different than what one proposal used over another, but it's the same enrollment throughout the process. The admin fee for Blue Cross, using $36.15, comes to $1,753,000 for medical administration. They have a $3.25 administration fee for dental. That's $171,000 annually. They have included a $50,000 technology fee. This is a one-time fee that's payable up front, provided, and it's not recouped unless the group does not maintain coverage through the end of the 3-year contract. They charge 30% for recovery through subrogation. Coordination of benefits is included underneath the admin fee. Retro terms, hospital bills, workers' compensation, anything that you go out and get money for back, it is 30% recovery. RX rebates underneath the specialty drug program are reverted back to the company. Blue Cross retains 15%. So those are in addition to the rebates that you get through the prescription drug plan. Medical runoff, they do charge 15% of claims to cover the runoff of claims. This afternoon I looked at the claims from January and February. It winds up being about $7.4 million, which winds up being about $1.1 million, $1.2 million, somewhere in that range. But it will vary. It'll vary based on what claims are actually processed after termination. So what the cost of runoff would be with Blue Cross would be determined by the claims that are affected after the end of a termination field termination. Aetna came with a bid. Aetna's bid included an $18.29 administration fee. That's $887,138 per year for the administration. They had a $2.51 for dental administration. That's $132,528. I put in a runoff fee of $1 million because that's a fee associated, while it's payable to Blue Cross for the runoff of claims, it's a cost that you would experience in the first year if you made a change. The fee waiver, I put in $887,000, but they would go up to $922 if enrollment generated to $922.
$1 million is only in the first year?
It's only in the first year.
Are we in the first year now?
You would be in the first year, September 1, for the runoff of claim.
So it wouldn't pertain to today?
So if you
No
terminate,
matter when we terminated that.
whenever you terminate this contract, what's going to happen is any claims that are presented to Blue Cross, they're going to process and apply the Blue Cross discount. And they're going to take 15% of any payment of claims as far as the runoff fee.
Every year, not just the first year.
Well, once your claims are off, it's over. You understand what I'm saying? So when you terminate with Blue Cross, if you terminate with Blue Cross, there'll be claims incurred and not paid.
Okay.
And that's why I'm using the 2-month number, because it's just on medical.
Yeah, it just
claim.
threw me off when you said first year. But
Well, it's first year, you might pay it in the first month, you might pay it in the first 2 months.
Okay.
It might string
I got
out
you.
over
I
12
got
months.
you.
But we're utilizing 2 months of medical claims only, no prescription. The fee waiver is $887,000. There's an implementation fee of $30,000 that they're granting to the plan, and $25,000 for wellness. The wellness fee is $25,000 a year for the first 3 years that they'll grant. The proposal I have that I received this week says $25,000. Now, if they've moved it to $100,000.
We did.
That's something other than the proposal I received yesterday.
Yeah, it's enhanced to $100,000 per contract year allocated to a wellness allowance.
So that's different than what I had right here. For a total cost first year of $1,077,000 now. Actually, if you looked at what they're taking in, they're actually giving y'all more money than they're taking in. It's the money that you would pay on $1 million or whatever the runoff fee would go to the coverage of claims that were incurred prior to the transition. United Healthcare came in with a fee of $1,473,000, $30. They had an admin fee on down of $104,544, and then $1 million worth of runoff. They also issued a implementation fee credit of $392,000. It's a 3-month waiver of fees. They had a $200,000 implementation fee that they would pay. There are stipulations that they would recoup it over the 3 years, depending if you terminated prior. They had $100,000 worth of wellness credits that are included in the proposal. They also included the COB underneath the admin fee, but the others were at 30% recovery. Anybody have any questions on the total cost of admin first year?
Mr. Cheatham, I'm sorry.
Jason, as far as what we paid this past year in relative to this, do you have a ballpark number of what we paid for admin, dental, kind of?
The dental is the same as what's quoted here. It's $325 a head. The medical, I think, is $36.40 right now. $36.40 instead of $36.15. So wasn't it $13,000? $12,300 additional. So it would be $1,765,000.
Thank you.
Mr. Fuller?
Thank you, Mr. Chairman. Mr. Allen, have to keep me on track here. It looks like to me, if we pull out all of these extraordinary fees, rebates, you name it, let's get down to just what these two companies, we have two companies here, we've got a third that is put in a presentation, but they're not present. So I'm going to restrict my comments to the two companies who are in place here. Each of them are saying they give us a 3-year commitment. Blue Cross is saying they're going to charge us $1.75 million a year. Aetna's saying they're going to charge us $887,000. Pretty significant difference. Dental administration, $171,600 versus $132,500. Now, the first year, the difference would be greater because of the rebate. But go back and address these recovery factors again. Because if I'm following it correctly, if I'm understanding it correctly, Blue Cross is taking a little smaller bite of the apple from these items that are being processed, our rebates, our refunds, what have you, that come about as a result of claim processing and what have you.
Well, when you look at a self-funded plan, it's a lot more complicated than what you can put on paper. Okay, it's a lot more involved. Even when you look at what we're looking at today, this is based on a proposal. Contracts differ from proposals, and you got to go through contracts, and you got to make sure the wording and what's included and what's excluded, and how we look at a rebate, and what applies to a rebate, what doesn't apply to a rebate, what drugs are counted as brand names, what drugs are covered as specialty drugs, what drugs are covered. It becomes an insurmountable amount of information you have to go through to get anywhere close to a similar information or close. When we look at this and we see coordination of benefits at up to 37.5% or up to 20%, it depends on what is defined as coordination of benefits. When you look at the Goshen Parish School Board and you look at what Blue Cross is showing as coordination of benefits last year, it's $12,500,000. Well, that number, if that number is actually what Aetna decides is part of coordination of benefits, at 20% winds up being $2.5 million. And what else it does, again, what do they determine? Send emails, we've talked about it, and the biggest part of that coordination of benefits with Blue Cross today are Medicare claims. Retirees with Medicare. It's part of coordination. Medicare pays primary, the plan pays secondary. Plan won't pay until they get an explanation of benefits from Medicare, and then process it through coordination of benefits. So, is that number 2.5 million? Is that number $300,000? It depends on what they count and what they don't count, but it's going to cost something. Okay. You look at RX rebates on medical. It's inside the proposal. Could you negotiate it away? Probably. If you sat there and you went through the contract and you identified the things that you didn't like, and as you went through the contract, you said, this one's going to cost us $40,000, this 37.5% is going to cost us $30,000. You know, we'd like this on a different format. That's part of the process. That's part of, you know, if you get to that point, you go through a contract. What we've gone through so far, even though it's been a number of months, it's very small on the scale of what has to go through to put a contract in place. You can't just sign a contract. You've got to be aware of what's in it. You've got to protect yourself. You got to have no knowledge of all the definitions and what is included and what is excluded. There's no way I could send out an RFP that says, y'all put it just like this. Because everybody wants to make it look more attractive on their end. Everybody wants to put their best foot forward, and everybody wants to make sure that somebody else doesn't not disclose something. So they shade it as much as they can to protect themselves on their bid.
Okay, I'll follow up to that. Somewhat related. I have been led to believe a situation exists, and you alluded to the fact that while Aetna apparently is going through a negotiation process with the Willis-Knighton system, they do not have an agreement with them, and I don't know what it's called. And if I'm incorrect, please, ma'am, you correct me. And this concerns me for this reason. Mr. Allman, you'll recall a few years back, there was a situation arose between Blue Cross, Willis-Knighton, and guess who was left out in the cold? Us, our self-insured plan. We had to sit on the sidelines, just waiting. We had no control over that. I want you to know, I was here when that came down. I'm not going through that again. And some of you sitting up here, you were here when that happened.
Can I respond to that?
Sure, go ahead.
To give Cindy a chance.
And by the way, they did work it out. Everything was fine, but there were a few restless nights there, particularly those of us that were deeply involved with the self-insured plan here for the boards and the school system. So, go ahead, sir.
The first part of your question. Yes, they're working a deal with Willis-Knighton for additional products. This does not affect the product. The product they're negotiating doesn't affect this product. They are working on getting negotiated fees, getting an ACO set up, or a tiered network, or a narrow network plan. Those are a lot of things you'll hear about in the near future, particularly with the onslaught of the healthcare battle we have brewing here in Goshen Parish between Willis-Knighton and Oshner's trying to come in and play and take a portion of the business. So you'll hear more about it if you come to this one. They all want market share, everyone. Market share is the ticket. How can they get more beds, more butts and beds? And so to steer is generally how you get bigger discounts. Discounts historically for PPO networks have been, and if you're talking about a discount, not trying to manage care, and that's what I'm talking about today is a discount. It's done by volume, it's done by steerage. How can I get more people to it? I'll give you a bigger discount if I'm the only person in the network. But if I'm one of everybody else, I'm going to give you a lower discount because that doesn't benefit me. I'm getting the people I'm going to get. So as you narrow a network, you get the ability to get more discounts. And you have to deal with that. And you have to deal with my doctor's not in the network, my anesthesiologist is in the network. You deal with those things. The products they're dealing with from this point forward are different than what they're proposing today.
Yeah, so we have a long-standing, I'm sure.
Would you please speak to the microphone because this is a video meeting?
Yes, sir. I would just like to reassure you that we have a long-standing partnership with Willis Knighton, and in fact, we have an executive from Willis Knighton that has joined us this evening. Bruce Stroud is here and can attest to the fact that our contract and our relationship is very solid. Our contract is not in jeopardy. It's not expiring. We're not in negotiations for a contract that would apply in this particular case for this particular proposal. What you've heard about probably in the marketplace is that we're working together on a new product that we're going to be jointly launching in the marketplace that will be jointly branded and jointly marketed between Aetna and Willis Knighton, and something that we're very excited about, very proud of, but that is not part of this proposal, sir. It's something that you could look at in the future for the school board if it made sense for the school board in some future year with Aetna, but it is not part of our proposal today.
Thank you for your response, ma'am. Thank you, Mr. Clark.
Does that answer your question, sir?
Yes.
On the next page of the presentation, there are the medical claims repricing. This can be looked at a number of different ways. Unfortunately, with repricing, there's nothing binding in anything that a repricing does. And I've had this discussion with the Aetna people when I officially got the proposal, and we talked about repricing exercises, how they can be shaded. I had this discussion with Mr. Bass about the fact that when we're looking at it, if we're using averages, it's an average. It's not an actual reprice claim. It's projected based on what they think the average is or what average they have applied to the claims just in mass. It's not particular. They pull all the in-network claims and they say, apply this discount to that. Well, your claims are different. Your claims are different this year, they'll be different next year. Who you use, who you go to, everything is different. That's what makes a repricing exercise very difficult. Because unless they're paying an actual claim and somebody's accepting that as a remittance, it's subject to either being up or down. We tried to get it on an actual reprice basis. The information we'll receive from Blue Cross will actual reprice claim. UMR, Aetna, UMR, United Healthcare, they produced it on an actual basis, on a projected basis, and then on a three zip code basis, a 3-digit zip code basis. The Aetna quote at first, when we got the information back, was a 3-digit zip code projected on first quarter of 2022. We sent it back, we asked them to reprice it again and give us actual repricing. They put it through the system, came back, 30% of them were actually repriced. The other ones, they said that there wasn't a substantial or I'm trying to think of the exact words. It wasn't credible to put it through and pay the other 68% of processing fee claim without an average discount. So when we're looking at this, we're looking at actual claims that are repriced by Blue Cross. Aetna's is 30% based on, or 32% based on actual, and then 68% based on the 3-digit zip code applied to in-network or out-of-network is the understanding that I have based on the latest repricing. This was the second repricing method. And then UMR Aetna is based on the actual TIN numbers and the actual claims they repriced. If you look at it, Blue Cross, they had $83,138,000 of billed claims that came in. They allowed of those claims $31,788,690. Out of network were $1,006,840, of which they remitted $315,000. So of $82 million, they remitted $32,104,000. They had the highest volume of in-network claims when you look at this presentation. And that's important when you look at it, how the network impacts you. While Aetna's proposal states they consider 97% in-network, there's a variant of it that they consider in-network because it is a hospital-based physician or a specialty referred by a physician. Out of the member's control. So in their scenario, they'll pay it as in-network. If they pay it as in-network, they pay anything less than billed charges, the member can get back. If they pay balance bill, if they pay the actual billed charges, the plan has a higher hit for those money. So it's a variable that you'd have to deal with one way or another. They say they hold the member harmless. By holding the member harmless means that y'all pay an additional fee for those claims. They pay it to where it's acceptable by the provider. So it's, again, when you're looking at this, you got to look at it. You got to say, okay, how much is this worth? How much is that worth? And that's where it becomes very clouded on scenes. But Aetna had 78,181,000 of in-network claims processed. They paid 27. This is the second repricing. This is 27,899,798. They have a national advantage program that they put $271,000 worth of claims through. Their projected allowable of $130,720. And I don't know that I verified this or not, but there is a 50% of savings fee, correct? Is that figured in this 130? And the difference?
Now there is.
Okay, so if there's $140,000 savings, they'd be $70,000 that would be payable. So that discount wouldn't be as great as what it is shown on paper. They had 234,702 not processed. That means the information we provided did not match up in their system. Either a TIN number or a provider ID number did not match. They couldn't either say it's in-network or out-of-network. So they didn't process those claims, and those are there. So there would be some possible discount associated with that. Even if it was out of network, they're going to pay a little bit out. They had 3,658,561 out of network claims, of which they paid 1,247,473. For a total of 29,277,995. And again, that's the repricing based on the second repricing. The repricing that they put on their guarantee is actually the first repricing, which would get up to a 67% benefit. United UMR, again, 79,904 of in-network claims, 36,636 is what their allowable would be. They had 993,000 of claims that couldn't be processed. 1,447,940 of out-of-network claims that they paid 521,032. It's a bunch of numbers, a bunch of percentages. Again, the hard thing is putting the weight to it. Looking at it and saying, okay, the initial repricing, where they used the projected numbers from first quarter of 2022, we're in the $24 million range, or 25 to $26 million range. And then you go to the second repricing, it's $29,000. The initial response to the RFP would have put it closer to $33 million, excuse me. So it's a variable number when you're not actually repricing the actual claim that occurs, and how much of the actual claim will be repriced as opposed to a percentage. Because because every claim that will be paid matters. Anybody have any questions?
And I think you explained it, and I just want to make sure I understood it correctly. So, I believe it was Scott that said there was a 97% match as far as claims. And I guess that would be under, if I'm looking at this, that would be under, in-network
Yes.
allowable.
But like I said, the issue becomes the percentage of claims that they have that they would claim as in-network because it's a forced provider situation. These doctors today are not in-network, and I verified with Thomas. The doctors that they're talking about is about 8% of claims that come back in as they're painted as in-network, but the provider's actually out of network because it's a forced provider. The person went to an in-network facility, they've got an anesthesiologist that was out of network. The person went to an in-network hospital and got a radiologist. There were roughly about 45,000 claims that were associated with that situation, based on the repricing model that they ran, based on the disruption model they ran.
And so that's where the 80.
That's where the difference.
4% match came from,
Right.
on those doctors that were not included in that.
Right. So you had 80% of the actual claims that were processed that were in network, and then 91.67% of the dollars that were in network, excluding those claims of a forced provider situation.
They were paid at a higher cost to the plan or to the individual.
Well, here they're just claiming it as out of network claim, and they're paying it. It could cost the plan additional money or the member additional money, depending on how y'all look at it.
Follow to that. Is that, those physicians are in network with Blue Cross?
Yes. Well, if you look at it, the vast majority, there's some, I'm sure there are not. Today, we don't have a problem with a forced provider situation, but these contracts are always up for renewal. These contracts are always being negotiated. You may have gotten a letter 2 months ago where the emergency room physicians at Krista Shumpert had gotten out of the Blue Cross network or agreed not to. Christus went out and actually hired a new ER physicians group that was in network, so it never impacted anybody. But this is something that can be a variable and change. Today we are not having a forced provider situation. Prescription drug repricing. Today, with Blue Cross, we get the deal they negotiated with ESI. So, whatever they buy a generic drug for from the Express Scripts, is the price of the school board pays. Whatever they negotiate the brand name discount, Blue Cross is not holding any part of the fee. The only fee on the prescription drugs that Blue Cross is receiving today is $1.50 per script. It's a substantial amount of money when you look at it, but that's included in, it's about $150,000 up in annually. But if you look at this number, $14,424,522, that includes the $1.50 per script. They're actually paid rebates for the claims that we ran through the RFP for $5,179,505. Those are today's rebates. Those are not projected numbers. So those were actually dollars that we received back. So we wound up with a net number on the repricing avenue of $9,244,927.66. We got Aetna's revised repricing yesterday. I put it in this information. $14,648,542 is the cost of the drug. So that's the ingredient cost and the dispensing. The rebates projected at $5,215,946.46. Now again, that's based on their formulary, on how they would project the drugs. As Cornelius? Yes. Who are Cornelius? Neil. Well, I saw it on the email, and I didn't remember what you said when you stood up, so I apologize. But some of the claims that were paid as income are covered, might be excluded. Some of the drugs that were on the formula list might be not. These are projections based on the claims that you got.
But our rebates are going to be on a per brand, all brands.
So today, you have a floor on both the discounts that you receive off of generics and brand name drugs, especially drugs, but that's the minimum. You'll actually get the full pass through, whatever that true cost of the drug is, unless it's less than the guarantee. Also, on the rebates, we have a floor, but you get anything that's above it. Now, when you say all brand name drugs, that's generally talking about the guarantee. It's not the full pass-through portion of it. And when we talk about a full pass-through, the full pass-through with Blue Cross says they give you all manufacturers' administrative fees and any other thing that's considered a rebate. Now, I don't know what's put into this proposal other than what I read, but it's manufacturer administrative fees, the other any other that's not in the rebate. So there are some fees that are pulled out of the top of the cost that could affect it. UHC, so they're wanting for $30,596 based on the current price.
What was the difference? You remember what the difference was last year? What the rest of the pass through? How much of the difference that made over what the guarantee was?
No, we did not have a guarantee last year. Full pass through was just pass through. Because of the RFP, we got a guarantee because we needed something to compare it to. Yeah, and as you can imagine, they're not retaining any of this money. They're going to shave, they're going to cushion what they're going to give. They're not going to give you 100% what they think it is. They're going to shift there and shave it. They might give you 85% or 80% whatever they expect. Because every dollar that they miss it by, they don't get. It's just coming out of their pocket.
So Aetna retains their prescription rebate, is that correct, under this plan?
Aetna's passing 100% of the rebates, but they're retaining the manufacturer's administrative fees and any other fees that are not deemed to be a rebate. And there's a list of items that you can read that's in the proposal. Other questions, Mr. Mayor?
Mr. Almond, we're about to run out of time, and I know some of us want to hear from our financial director, Vanguard, so if you could,
How much time do we have? 30 minutes.
probably 30 minutes.
Can I go through the overview?
All right,
Blue Cross.
if you would,
And
please
that's-
allow for time.
And again, this is just my observation, and what I see as a plus, and what I see as a minus on the information on paper. Again, these people have their story to tell about what they anticipate, what they can do for you with integration, and how their plans can work. I've questioned some of the coverages from people and some information. I put some basic information down here. Blue Cross Blue Shield is one of 35 independent, locally owned Blue Cross Blue Cross companies that combine provide coverage to over 100 million members in the United States. Blue Cross Blue Shield Louisiana is the largest health insurance provider in Louisiana, providing benefits to approximately 1.8 million Louisianians. Blue Cross Blue Shield Louisiana covers 494,000 employee lives, with 37 groups over 1,000 lives. And Blue Cross Blue Shield currently administers plans on 22 independent school districts with over 50,000 employees in the state of Louisiana, and all plans associated with the office group benefits. As you know, many of the smaller school districts are covered by the office group benefits. I think there's about 45 or 50 of those that are covered. The medical admin fee, as far as the highlights of the offer, $36.15. That's down from $36.40. The dental administration fee is $325. It's a 3-year step rate, so it does go up in years 2 and 3. There's a $50,000 technology credit made available at no additional charge. They would offer programs of cardiac services that could potentially save up to $500,000. It's generally something they provide for a 25-cent per employee per month fee. It's something that, as we were talking about it, they said we can throw that in if they'd be interested. The discount guarantee, they have a discount guarantee with up to $900,000 in administrative fees at risk. If discounts fall below between 58 and 60%, performance guarantees included. Largest provider medical network with 99% of claim payments in network. Largest dental provider network in the dental aspect. Actual repriced claims at 61% of overall discounts. Full pass-through on prescription drugs. Has administered the plan for 26 years. Concerns, of course, the highest fee out of the 3 bidding. However, with the RX pass-through and other fees charged by bidding carriers, it makes it less of a factor. $50,000 technology fee has to be repaid if you terminate before 8/31/24, and runoff cost if the plan is terminated is 15% of payments. I'll look through the Aetna information that I provided to y'all. Aetna is a large national company owned by CVS Caremark. They provide health insurance to approximately 16,902,000 members in the United States. In Louisiana, they cover approximately 60,000 employee lives with 7 groups over 1,000 lives. They do not currently provide any benefits to Louisiana school districts, but cover 90 public and labor school districts outside of Louisiana with approximately 415,000 lives. Medical administration fee is the lowest at $18.29 per employee or per retiree per month. Dental administration fee is $2.51. It's a 3-year step. As Scott indicated earlier, it's a 3% increase each year. Up to. There's a $30,000 implementation credit and $887,000 in medical administration fees waived. 12 months of admin fees are waived up to a max of $922,000 per proposal. Claims target guarantee and discount guarantees are included. Complex RX pricing rebates or competitive RX pricing rebates on revised repricing. Significantly greater impact in inpatient and outpatient discounts shown on repricing. The concerns that I show, network disruption report shows 80% of claims of the providers in network with 91.86% of payments included. Significant number of hospital physicians labs not in network, 3% of payments, 1,447,037 of payments for 29,000 claims. Significant number of preferred specialties not in network, not in the network, 2.6% of payments, 777,000 on 14,523. Non-network issues involved with the cost of both our school board or its employees, and both depending on how the claims are processed. Overall, approximately 19% of current claims and 8.32% of current payments would have been out of network based on their disruption report. Smaller 3-tiered network for dental still does not have the dental participation, or dentist participation that we have currently. They do have a claims target guarantee and a discount guarantee on the first year. However, it's based on actual fees collected, and if you don't pay any fees in the first year, there is no dollars number at risk. So, at least that's how I read the proposal. You waive the potential cost. So, what he's saying is that they have decided to waive that arrangement, that it would not be on collected fees, but on billed fees of the medical administration. So you would have up to 2% for every percent they missed it by, less 1. So if it's 67% and they miss it by 5%, they're going to give you 10% off of the 887 number. They miss it by 10%, they're gonna give you 20% off the 887 number as far as the admin cost. That was not in the proposal. The proposal actually showed it that if the fees, it was based on fees collected. So if they did collect any fees based on the waiver of the fees, there was no penalty for them not hitting the mark. So again, I'm basing this on what was on the proposal. Subrogation and other coordination of benefits and other contracted services, showing an additional up to 20% of the funds recovered. Current Blue Cross Blue Shield includes coordination of benefit services administration over the last 12 months. Blue Cross Blue Shield shows approximately $12,775,000 of other coordination of benefit services savings. The majority coming from coordination with Medicare for retired population. If that applies 20%, that's $2,555,028. Subrogation and other contracted services were shown at 37.5. I know Thomas said that the coordination of benefits was at 20.
I hate to interrupt you, but at the end of that point you said you asked several times for specific details of how this would be applied. Have those been answered, and if so,
well, it's applied to coordination of benefits and outsourcing. Now, how I've been to answer that is how I was told that the fee was 37.5 because they were outsourcing. And I would imagine at some point it was 37.5%, and that was retaining some portion of that 37.5. But when I questioned it, Thomas came back and said they would accept the 20% lower number. So they would forgo that they would receive, but would still pay the outside vendor that would coordinate the coordination benefits. Subrogation services at 37.5. Thomas has indicated that it would be the 20% as well, because they wouldn't take their cut of it. So it would be less than that. But again, when you're looking at these things, you're looking at, okay, here's a fee, here's a fee, here's a fee, and where are the fees coming from? And that's what I was trying to get to by looking at the proposal. And as you go through this process, whoever you contract with, you need to go through the contracts with the same type of question. Once it's written in a contract, that's what you get.
Question. I just don't want to get through here without asking it again. One thing that's concerning is when we see a network disruption report that shows 80.64% of our providers. You guys have information
That's claim. That's not payment. That's actual claim. Or I guess that would be providers. That's correct. That's correct. It's providers.
So that's actual doctors that our people see. Y'all are saying that 97 some odd or 97%.
In other words, in cases, in instances, their membership is going to the doctor, maybe provided they're very small dollars. Maybe 500 there, 1,000 there. What's causing your plan is more impactful. And 97% of your claims dollars is where we're matched. So sometimes we get caught up on.
Didn't you tell me you're counting that 8% as in-network?
Yes.
Because they're forced providers.
Yeah, absolutely. Yeah.
So those claimants are out of network. They're counting them as in-network because it's a forced provider situation, meaning you as a patient had no choice to go there. There's still no contract between that provider and that.
Yeah, so in those situations, we treat them as in-network.
But we don't pay them as in-network. I guess would be the question. You treat them as in-network because they're referred by a network physician. But they're not. Are they actually in-network or are they not actually in-network?
They're not in-network.
Not today.
Yeah, okay, so.
I mean, my concern here is one.
Yeah, it's a great point. And we're really talking about hospital-based providers such as anesthesiologists and the like. And with an account of this size, it's going to give Aetna the ability in the negotiating leverage to approach those groups, those anesthesia groups, the emergency room groups, and to be able to negotiate a contract with them. Does that make sense? So while they may not be participating today, they will be participating in the future.
It does make sense, but, I was just wondering why the discrepancy in the two numbers, because one, it sounds like we're assuming that because it's our account, that y'all gonna get that work with the providers, but they're not there today.
Some hospital-based providers may not take that work today. Some anesthesia groups, or ER groups, or radiology groups.
Yeah, those aren't $500 bills. Usually.
So if you look at your entire population and you do the flip side and say, if we had this case, there was a significant amount that would fall out of that work. If it was our case today, which are coming carriers, there's a greater number that will fall out of our consider that will fall out of our network if we were to look at it as a reverse. If you look at it where we're coming in, it's a small number. If you actually flipped it and say what it would look like if we were switching from ethnic to another, that number would be large. We would capture more of your total the total spend than if it was a flip around. I mean, if you were to go back, you would, a lot more of your in-network people that would be with us will fall out of network. Sorry, a lot. I mean, I don't have the numbers quite I can get for you, but I think it's greater than 15%.
Yeah, and my hang up here, I guess, is the difference in those two numbers as we sit today. And that could be passed on to the employees today. I understand that our account is a big account and allows you a lot of negotiating power, but is there I don't know, it seems like you would go to those providers and say, hey, we're bidding on Exposure Parish's business for 8,000 lives. Can we count you in network when we're doing this?
So sometimes we do that recruiting. We got this RFP in short order, right?
Right.
We got it in short order, and we moved it around. We did a lot of back and forth to get it right. It's not a normal process. So what generally happens is it's never perfect when you switch carriers. But what is the normal part of the process, whether it's us or any other payer, they're going to go out and say, recruit. Well, most doctors are busy. They say, well, wait till you get that account, then I'll learn.
I get it.
Yeah, so tell us when you get the account, but they don't want to go through the process if you don't have the account today. Now, when you get the account, then the conversation really is standard practice. Regardless of who you contract with, United, Blue Cross, or Red. So anyway, we all do the same thing, and that happens when we get the account.
We do have 99% of the claims network paid. We do have 99% of the claims paid in network with Blue Cross today. The claims that is referencing out of network, or particularly claims that are outside the state that were not in the Blue Cross Louisiana network, but were networks that we associated with the Blue Cross Blue Shield Texas, Blue Cross Blue Shield Oklahoma, that were considered as a network processing claims and paid at a discount. The last thing before I turn it over to Nisha, not the last thing, a couple of things. Number one, those doctors are not network today. So if you pay a bill on that doctor today and you pay it less than the bill charge, the member can be bounced unless they negotiate directly with that member to get an acceptable fee that they'll accept. And that will cost you some percentage of sales. If they do pay it at bill charges, that protects the member, but that costs the plan substantially. So again, when you're looking at this, some things are said to be as counted as in network, but truly we're not in network. And that's why I've taken so much time going through these proposals and going through the information to try to make sure I'm not missing something. And I questioned that to Thomas. Thomas and all agreed and sent the information back and forth. Beyond that, I'm going to turn it over to Nisha. There are some things that if you terminate before the date can cost substantial money, particularly the RX rebates are on a 90-day after the quarter ends, it's paid quarterly, and the rebates are reimbursed 90 days after the end of the quarter. So if you terminate, Aetna retains the rebates according to the proposal, and And that could mean up to 6 months of rebates, which if you believe in either one of the 5.1 or $5.2 million, it's 2.6 or 2.5 million. But it's in the proposal. It's in the proposal that you sent us. Anyway, that's what I have in terms of.
Okay, I have one question. It's in the proposal, so there were several things that we went through that were in the proposal that have been changed while we're sitting at this stage. Wellness, the park, match, the park where the rebates are then held for 90 days. I want to hear what each has to say too, but of the concerns, I would also want to give Blue Cross a chance to address the concerns listed and Edna to address the concerns listed and hear what they have to say, but there just seems to be so much change that I'm not having difficulty following it. So I don't know if we can do that, but we're running very, very short on time.
I'm going to turn it over to Nisha. The constant change has not been a part of the bid process. You turn the bid in and you give it, keep coming back to see what folks done. You don't sit in a meeting and say, oh, we're going to change that. Oh, we're going to do this. That's not part of the way things are handled.
I'll be very, very brief. Just to give, I know several of the board members have asked for my opinion and how I feel about this. To make it very simplified, very, very simplified, we're dealing with two big aspects. We're dealing with our claims and our claims processing and the cost for claims. And we're dealing with our admin cost. And Jason's already pointed it out, and I know y'all know admin cost is fixed, and that's what we can negotiate, and that's our fixed rate. Claims are the unknown, because you don't know who's going to get sick, you don't know what's going to come up. And what scares me, or where I hesitate with the Aetna proposal, and just being clear, is that part of it is repriced based on an average of 3-digit zip code. That we don't have the full 100% reprice on actual. Although Aetna came in with a very, very competitive bid, and they've been very competitive. They've had a lot of good things and a lot of great things that they've offered in their bid, and I'm very, very appreciative for that. My concern is because it is a newer market for them as far as now negotiating with doctors and negotiating new rates and things like that, that we're unable to get an actual of what it would cost us. And for claims, we're talking about millions and millions of dollars. Our claims are $40 to $50 million a year. That's not a number I like to be unknown or an unknown network bid. Admin, I'm very appreciative of the waiver, very, very, very competitive bid there. Obviously, the numbers line up. But an admin's a known, my claims are what I'm worried about. That's our biggest ticket item. It's $40 to $50 million a year. And when that's an unknown of what that's going to cost us as well as our members, I don't want our members to be hit with a balance bill and extra cost at the end. So that's kind of the short and sweet. I've got a lot of other things I can say, but that's kind of how I want to leave that unless y'all have questions.
Okay, so I just did the addition, add each up, subtracted. So based on that, we're $3.4 million apart from the bids. But based on what you're saying, and the 30% repricing, and the rest done on an average, there's no way for us to know that's accurate. So it's basically a shot based on an average and 3 digits.
It is, and repricing the 30%, the 32% that they did reprice, that was a $3 million swing. When we've got 68% that's an unknown, I don't know how many millions of the dollar swing that is in claims. That's my concern. And because of time, that's my biggest concern. That's what I feel like is important for me to say today. Thank you.
I wrote down a bunch of questions, but I don't know if we have time to answer all my questions.
2,000 bodies, multiple contracts that we would have to get moved. If we need to, if the board chooses to move that direction, it is something we need to do sooner rather than later. And so we do need to make a decision pretty soon.
But just to be clear, we did ask for this information in August of last year, correct?
We did. Now, as you heard, Aetna has had 4 or 5 months for theirs. So Aetna did not get theirs in August. But they have had 4 or 5 months and they have been working on it during that time frame.
So, Meritain is a technical company, so it's paperless. But everyone in our region says that's a program. When it's a Meritain program, they want to see the specific quote, because we specialize in different things. Some people want to piece their plan together, and then some folks want to have a comprehensive offering with a name brand, they may not know Meritain. And so we've got the RFP in case of the program where they're wrong. In March. So we hit my desk in March. I don't know. There's only a couple reputable payers out there. And there's one with a Fortune 500. Those pieces, 99.9% of the time, hit my pockets. Or they may hit that ordinary pockets. If they want to see both options. I'm not saying it's a mistake here, but what I am saying is, generally speaking, top 5 insurance carrier, we see those quotes 99.9% of the time. So I only recently saw it a few weeks ago, and obviously it's been piecemeal trying to get it right to get you where you want to go, because every client wants something different. Just like somebody can complain about, I love this payer. Well, I may not love this payer, but they may love it based on what the employer decides and benefit design should look like. So we're trying to get it right too. So if there's no question there, and there's no question and answer period, then everything gets rushed. And that's what you got.
So you weren't prepared because of the time crunch.
I would take a little bit, take a similar swing to what Sean's saying in the public and municipal sector.
I'll be very brief, but just to say that a group of your size, with this much membership, we work these proposals all the time. It's what our team does, and quite a large team it is. Typically, they are, obviously, it's included in the initial RFP release. There's typically a technical section that is an extensive questionnaire that is scored, it's evaluated for each carrier. There's a corresponding financial section that is scored and evaluated in a very objective way. Saying that, there's typically a second phase, which is called a best and final offer. This is the initial proposal. Go back to the carriers that advance. It's a smaller group. Here's your best and final offer. It was never our intention to piecemeal improvements to our proposal. That was an unintended consequence. We were attempting to show our commitment and earn your business. But in lieu of having a best and final offer that was formalized or an objectively scored and evaluated RFP, it made that difficult. The last thing I'll say, the discount guarantee analysis, it was frustrating to us too. We wanted to deliver to you provider-specific discounts. We didn't have the book of business membership to be able to do that. Going 3-digit zips was a safer way to not overstate or understate our discounts. I bring your attention back to the 1.6 claims target guarantee and that effective discount formula. Sorry, but thank you.
I'm getting the impression that they submitted information today. Mr. Thomas said he had gotten some information from most recently. What kind of information? Does he have access to anybody else's information?
We do have specific Blue Cross information that we had to send them, like for the repricing. There's certain information that
that Jason has had to send for them to be able to complete the RFP. Is that the information you're talking about? Because they do have Blue Cross information, or our claims information. I'm not going to call it Blue Cross information, they have claims information. But we had to provide that claims detail so that they could perform that repricing. Yes, sir.
Alright, and we do have one, I don't want to get out of here with Mr. Kim, you guys. You can wrap it up, we'll listen very fast if you guys.
Folks, I'm really concerned about this. I'm a changed person from the last time you saw me because I've seen life from a whole different perspective in my new job. But I'm going to make a couple of statements, and I hope that you don't take it wrong. But I've been through the bid process now a whole bunch. And I have to be frank with you, I've never seen proposals that are in perpetual motion. Okay? I'm worried about that because I'm going to use a little jest here, but if we wait it out 3 or 4 months, we may get a pretty good plan. If we start allowing them to start going against each other. But I'm a little bit worried that this process of getting the proposals to us is creating a situation where things get changed. And I hear concessions today. And I'm really worried about there having been a deadline for certain things. And these deadlines may be thrown out the window. So I'm worried about that. I'm also worried about there's no other Aetna business in a school system in the state. And so I'm worried that it's a situation that Bossier Parish employees are going to be the guinea pigs on this in the hopes that a network is completed. Okay, are they going to do this on our backs? So that's a worry for me. It's basically asking you to gamble. You already know it's your thing, but it's asking you to gamble. So I really hope that you look at these things that I've said about it, but vote your heart on it, and know that there are a lot of people that think that you've done a pretty good job already with what we have. Thank you.
Brad, you want like 30 seconds?
We have the current claims information provided in a timely manner. United Healthcare provided several different mechanisms on how they reprice claims, and they reprice them over the country to make sure they make that clear that the claim was requested from us, and we were able to reprice all claims. United Healthcare all the same claims that we have. That's all I have. Thank you for your time.
Real quick, Brad, how long would it normally take to do this RFP? Just average.
Besides, we had a deadline of March 20th. We received the RFP February, so we're looking at maybe a month and a half.
We asked for it in August, that's what I'm trying to determine is where there's the length of time, I guess, and I understand what the maritime and that side. We have to wrap it up. That's what I'm trying to figure out is I feel like we asked for it plenty of times, so that's my question. How long?
Nice one. Thank you.
Light of the information that's been provided to us tonight, and out of an abundance of desire to alleviate any further disruption to our healthcare plan. Lord knows we've had enough. I'll make the motion that we remain with Blue Cross Blue Shield and move forward. Let's put this puppy to bed. Let's move forward. They've done a good job. Aetna, thank you for your efforts. But can't go on maybes and last minute changes. We've got to go on hard facts.
We got a motion by Mr. Miller, second by Mr. Williams. Motion carries. Meeting adjourned.
Board, if you'll take a 5-minute break.